Urinary system, where will it come from?
Intermediate mesoderm.
Mesoderm, very good. Okay, so you remember that we have several types of mesoderms, the paraxial, intermediate, and lateral plate mesoderm. The intermediate mesoderm is the one which is responsible for giving the entire urinary and genital system. So if we kind of look at the kidneys, this is the first part of the urinary system, you will see that we have several kidneys. We actually have 3 types of kidneys in the embryo. The 3 kidney systems are called pronephros, mesonephros, and metonephros. So there are 3 pairs of kidneys which appear in embryo. The definitive kidney will be the metanephron. So the nephron part of the kidney, right, so the excretory system, will be arising from the metanephron. If we look at the picture here, so this is your embryo, approximately 5th week of development. We can see that this is the gut tube, right? This is the developing liver. This is the gallbladder. Here we have the cardiac bulge. That's where the heart will be. We can see that this is the endodermal gut tube with proliferating respiratory diverticulum right here. So you remember last class we have talked about it, that here the last part of the hindgut, what happens to it? It dilates and becomes cloaca. Cloaca folds backwards and creates this structure. How do we call it?
Proctolem.
No.
Urogenital tract?
It's going to be primitive urogenital sinus. Okay, so this is the primitive urogenital sinus, this part right here. What will urogenital sinus become?
Future primitive bladder. Anal.
It's going to be the bladder. It will become the bladder. Urogenital sinus will become the bladder. So remember that. We can see that behind the gut tube, there is a kidney system that consists of 3 parts. So we have the pronephros in the cephalic region, the mesonephros in the middle, and the metonephros in the most caudal end. On this picture, every 3 system, like all 3 systems, they appear together. They appear simultaneously on this picture, but that's not true. If pronephros are present, meso and meto aren't. So the first system to appear are pronephros. If you see pronephros in the cephalic region, meso and meto haven't been made yet. They are not there. If you see mesonephros and metonephros, pronephros have already disappeared. So this is a mistake in the book because they show that all 3 kidney systems are together at the same time. That is not correct. Pronephros, if you see them, meso and meto haven't been made yet. If you don't see pro, that means that meso and metonephros have been made already. So the first kidney systems, this is the pronephros. They're common from the intermediate mesoderm, and they are located in the cephalic region. Which structure is going to be here, occupying majority of the space in the cephalic region? Should I repeat the question?
The heart?
The heart is here.
Oh, sorry.
Pharyngeal arc?
Pharyngeal gut tube is going to be here. So in this particular area, that's where the pharyngeal gut tube will be. Pharyngeal gut tube will occupy majority of the space in this area. As a result, it will push the pronephros out of this area. So if they ask you why do pronephros disappear, it's pharyngeal gut tube's fault because it's actively starting to proliferate. It forms these pharyngeal arches. Your head and neck structure start to appear, so they push the pronephros out. Pronephros are only functional for about a week. That's it. So from the beginning of the 4th week until the end of the 4th week, they are functional. They are producing a little bit of urine. But you know, in embryo, urine is not urine. It's technically water because all of the toxins are removed by placenta. You remember that umbilical artery is going to the placenta. So it's actually dropping all of the toxins there, right? So pronephros are only functional for approximately a week, and they are being pushed out of the cephalic region. They are forced to degenerate because of the pharyngeal gut tube, because pharyngeal gut tube is constantly expanding there. As soon as the pronephros disappear, mesonephros appear. So when do mesonephros appear?
After a week.
At the end of the 4th week. Okay, so in the beginning of the 4th week, pronephros appear. At the end of it, they disappear. That means that at the end of the 4th week, mesonephros are appearing. There's one more thing that you need to know, that pronephros, there are about 7 to 10 of them. So 7 to 10 little tiny clusters that are in the cephalic region, and they are functional only for a week. That's it. There's nothing more to talk about them. So as soon as the pronephros disappear, mesonephros appear. And as you can see, they are also forming a little tiny clusters. You can see that they're also having some kind of gatherings of intermediate mesodermal cells. If you look at the pronephros, if you look at the individual mesonephron, you will see that it has the S-shape appearance. So if I go back, this little tiny structure, this is a unit of mesonephron. It will have S-shape appearance. Each and one of them at different levels, these clusters of mesonephrons, they will have S-shape appearance. At one end of this S-shaped mesonephron, you can see that blood vessels are starting to appear. Could you tell me, where did these blood vessels come from? What will give rise to these blood vessels?
Mesoderm.
Which kind of mesoderm? Where we are, where did the structure come from? Intermediate mesoderm. That means that intermediate mesoderm will also give rise to this blood vessel. This blood vessel at the end of this one end of the mesonephron is going to be actively proliferating. It's actively coiling, creating glomerulus. This glomerulus will be connecting to the dorsal aorta. Somewhere there at the back, you will see that there is a dorsal aorta. So each of these glomerulus, right? So at a bit of a lower end, at the lower level, you will see that there's another S-shaped mesonephron, and then another S-shaped mesonephron. At one end of them, you will always find glomerulus, this knot of the capillaries, and these glomeruli are connected to the dorsal aorta, which is going to be a bit behind. So technically, what's going to happen with this glomerulus? It starts to be filtrated. So the blood that is coming from this dorsal aorta, it's actively starting to get filtrated. So now this ultrafiltrate, which you have created, right? So you're filtering the blood in the glomerulus. So now this ultrafiltrate starts to push through this S-shaped mesonephron. So this tubule, right, this excretory tubule, this S-shaped excretory tubule kind of behaves as in U, like proximal convoluted, loop of Henle, distal convoluted. So this S-shaped tubule is the same thing which is in U. We need to drop this ultrafiltrate somewhere. So where do we drop it? At the end of this S-shaped excretory tubule of mesonephron, you see that there is a duct starting to form, which is called mesonephric duct. If I go back, you can see that each of the S-shaped excretory tubule of mesonephron opens up into this mesonephric duct. What is another name for the mesonephric duct? It is also known as the Wolffian duct. This mesonephric or Wolffian duct will open up into where? Where does it open up?
Urogenital sinus.
It will open up into the urogenital sinus, which is your future bladder. So now all of this ultrafiltrate that your mesonephrons are creating, it ends up in the bladder. So if the embryo needs to urinate, right? Bladder is filled, so embryo needs to urinate. Where will this urine go? It will go to the cloaca. From the cloaca, it will go to the proctodeum. It will go to the proctodeum. So through the anal canal, the embryo will be peeing in this early stage. So the mesonephros are in the middle part of the body. So they are somewhere in the upper thoracic to upper lumbar region. Okay, they are functional for a couple of months. So they're functional for 2 to 3 months. They actually, that's how the embryo filtrates its blood. But mesonephros will also disappear. Okay, so they will also disappear. So could we quickly recap? So mesonephros, they are clusters of what? Where do they come from?
Intermediate mesoderm.
Intermediate mesoderm. So you're going to see that mesonephros are clusters of intermediate mesoderm. What is their shape?
S-shape.
S-shape. And these mesonephros, this intermediate mesoderm that gives you mesonephros, creates an S-shaped excretory tubule. So this is a tubule. At one end of this excretory tubule, something happens. What are you going to do here?
You have a glomerulus.
Glomerulus. Who will give you the glomerulus?
Intermediate mesoderm.
Intermediate mesoderm as well, because you remember that blood vessels, they will also come from the mesoderm where you at, right? So where you are, and you're in the intermediate mesoderm. This glomerulus will connect to dorsal aorta, the biggest vessel that you have there, the dorsal aorta, it will connect to. Okay, the blood within the glomerulus starts to get filtrated, right? So this ultrafiltrate that you have created starts to run in the S-shaped excretory tubule. So now this ultrafiltrate goes here. What is at the end of this S-shaped tubule?
Mesonephric duct.
Mesonephric duct. And you're going to see that it's a long structure, and each of your excretory tubule will open up into it. Each and one of them will open up into the mesonephric duct. So you can think about mesonephric duct as a common ureter, basically, okay? It's like a common duct which collects all of this urine. But again, when I say urine, guys, it's not urine, right? Because all of the toxins are removed by placenta. This is just watery fluid. It is free of toxins. It doesn't have anything like that.
Does the pronephros produce any ultrafiltrate?
Good question. In some books it says they do, but in our book it says that they are not really functional. So in Lungman, it's written that they are not functional, but when you study for USMLE, for example, in step 1, it's written that they are functional, for a week. But because it's for this exam, they're non-functional. They are kind of appearing in the beginning of the 4th week. End of the 4th week, they're disappearing. What is 1 week in embryo's life? It's nothing, okay? So that's why in our book, they are non-functional. Okay, so this mesonephric duct, where does it open up?
Urogenital sinus.
Into the urogenital sinus, which is your future bladder. What is another name for the mesonephric duct?
Wolffian duct.
Look at this. Here, this is your mesonephric duct going downwards. Laterally to the mesonephric duct, another duct appears, starting from the 4th week as well. Another duct is starting to arise laterally to the mesonephric duct. This duct is para-mesonephric duct. Could you tell me where did it come from? What do you think?
Intermediate mesoderm.
Intermediate mesoderm. This entire area is intermediate mesoderm. So of course, paramesonephric duct will also arise from there. What is another name for paramesonephric duct? So if this is the Wolffian,
Mullerian.
Mullerian. Paramesonephric will be the Mullerian duct. So as you can see, it doesn't matter if you're a boy or a girl. Each embryo will have two ducts, mesonephric, and anterolaterally it will have paramesonephric duct as well. Doesn't matter, boy or a girl. If I'm a boy, I need to get rid of which one?
Mullerian.
Paramesonephric. So I need to get rid of Mullerian or paramesonephric. If I'm a girl, I need to get rid of the mesonephric one. So a couple of months later, the mesonephros, even though they are functional, they degenerate. The degeneration starts in the in the cephalocaudal sequence. So you start from the head and you degenerate downwards. Why mesonephros will degenerate? You will answer to me this question after we talk about metanephros. So you will compare what is the difference between them and you will tell me why would they degenerate. Now, metanephros are here, right? You can see that metanephros, we have said, is the definitive kidney. That's the one that you will have, adult. And it is at first located in the pelvis, as you can see, right? So it is in the pelvical region. This is the mesonephric duct, which is opening up into the urogenital sinus, right? So it carries the urine from the mesonephros all the way to the urogenital sinus. You're gonna see that somewhere in the pelvic region, the mesonephric duct forms an outgrowth. This outgrowth is known as the ureteric bud, right? So somewhere in the pelvic region, close to cloaca or hindgut, you will see that mesonephric duct gives you an outgrowth called ureteric bud. Ureteric bud starts to invade into the metanephric tissue. So this bud goes into the metanephric tissue. So what happens next? As the ureteric bud invades the metanephric tissue, it dilates, forming a renal pelvis. Renal pelvis starts to divide and it creates major calyces. Major calyces start to divide, they give you minor calyces. Minor calyces start to go deep into the metanephric tissue, creating a bunch of collecting ducts. Okay, so a bunch of collecting ducts are there. So which system did we just made?
Excretory.
Urinary system.
The collecting system.
Collecting system. The system is called collecting system. So from the collecting ducts to the minor, major, renal pelvis, ureter, this is actually collecting system of the kidney, right? So collecting system of the kidney. So where does collecting system of the kidney arise from?
The bud.
The bud, from the ureteric bud. Who has give you the bud? Mesonephric duct. So is it correct to say that technically, not directly, but technically, collecting system of the definitive kidney actually arises from mesonephros? Not directly, but technically that's correct, because these mesonephros will give rise to the mesonephric duct, which gives rise to the ureteric bud, which creates this entire collecting system. So remind me, what is this tissue?
Intermediate mesoderm.
It used to be, but now it has a bit different name. Metanephric, right? So these are the metanephros. So you can see how this ureteric bud actively proliferates within the metanephros. So these are the collecting ducts of the ureteric bud. They're somewhere in the cortex, right? And this surrounding tissue is metanephros. And yes, metanephros have come from the intermediate mesoderm as well. So we magnify to this portion. We're going to look right into it. What is the next step? So yes, I have made the collecting ducts. They're within the metanephros. What is the next step? You can see that this is my collecting tubule. This is the collecting duct. The surrounding tissue is metanephric tissue. The appearance of the collecting duct within the metanephric tissue causes metanephric tissue to condense. So at the tips of the collecting ducts, it starts to condense. It starts to actively proliferate there and condenses, creating some kind of clusters which become renal vesicles. So why within the metanephric tissue renal vesicles appear?
Because
Why are they appearing?
Of the metanephric.
Sorry?
Condensation of the metanephric.
Yeah, so condensation of the metanephric leads to appearance of the renal vesicle. But why do renal vesicles appear?
Due to the appearance of the collecting duct.
Due to the appearance of the collecting duct. So hypothetically, if collecting duct did not appear, would you have renal vesicles in the metanephric tissue?
No.
No. So remember that only the appearance of the collecting system within the metanephric tissue causes your metanephric tissue to react. It causes it to kind of stimulate the progression to become something. So only if collecting system appears. So what's going to happen to this renal vesicle? Well, it dilates, it starts to grow. And do you see which shape is it aligning? It's kind of like an inverted, but it is the S shape. Where did we see the S shape? In the mesonephros. You remember it was working, everything was great. This S shape was working. At one end, we have the glomerulus. At another end, we will send the urine somewhere. So this renal vesicle, which remind me, where did the renal vesicle come from? Which tissue have given you renal vesicles?
Metanephric tissue.
Metanephric tissue. So metanephric tissue created these renal vesicles. These renal vesicles dilate, elongate, and keep on dilating and elongating until the entire nephron is created. What does the renal nephron consist of? Well, the renal corpuscle, proximal convoluted, loop of Henle, and distal convoluted. So you can see that the entire excretory system of the kidney, right, the entire nephron arises from where?
Metanephric tissue.
Metanephric tissue. The collecting system of the kidney arises from? Technically, you're right, but directly it arises from? From the ureteric bud. It arises from the ureteric bud, because you remember that ureteric bud was invading this part right here. So if I ask you this question, where does the kidney come from? What would you say?
Depends which part.
Exactly. You'll say it depends which part. Okay. You'll say, are we talking about collecting system or are we talking about excretory system? You can say intermediate mesoderm. Technically, that's also correct because both mesonephros and metanephros come from intermediate mesoderm. So technically, kidney as a whole, it does arise from that germ layer. But still, we have two systems, collecting and excretory system. They come from different things. So a super important question. Why mesonephros die? What do you think? So here is the overview for you. Why mesonephros die? What's the difference between mesonephros and metanephros? Something happens.
No collecting.
Sorry?
Is it because it doesn't have a collecting duct?
Kind of, you're right. It's because it doesn't have the collecting system. So why do mesonephros die? Because they do not get penetrated by the ureteric bud. Why do metanephros live? Because they do get penetrated by the ureteric bud. That means that ureteric bud must have some kind of anti-apoptotic growth factors. So if it is present in the tissue, it inhibits that tissue from dying. So hypothetically, if ureteric bud was somewhere here and it was invading my mesonephros, will they die? No. So this is a very common question. Why do mesonephros undergo apoptosis? What's the answer?
You don't get invaded by your territory.
Exactly, because they do not get invaded by the ureteric bud. That's why. Okay. Okay, we talked about it, right? So kidney develops from two sources technically. Yeah, and you start the urine production 10th week. So from the metanephros, the true production begins. So could you tell me how is the urine passing right now? So it's from the metanephron to the ureteric bud, which is the collecting system, the entire collecting system, then to the
Mesonephric.
mesonephric duct, and then urogenital sinus. So do you see the urine right now, even though it passes from the ureteric bud, like not from through the ureteric bud, it still has a bit of the mesonephric duct here as well. So urine will also travel through the mesonephric duct just a bit. Okay, so that's what we talked about. So we have to answer a question: why metanephric tissue does not undergo apoptosis? Why is it actually staying alive? It is staying alive because of the ureteric bud, because it invades the metanephric tissue, right? So how does it stay alive? Because your collecting tubules of the ureteric bud, they secrete growth factors, such as fibroblast growth factor 2 and bone morphogenetic protein 7. These two growth factors are anti-apoptotic. They inhibit metanephric tissue from dying. So the reason why metanephric tissue actually becomes the excretory portion of the kidney is thanks to this BMP7 and FGF2. But who makes this BMP7 and FGF2?
Ureteric ducts.
So the collecting ducts of the ureteric bud, yes. Okay, so the rest, I don't think it's important for you. Okay, diseases. We have polycystic kidney disease. There are two types of them, recessive and dominant. Recessive is less common, dominant is more common. The difference between them is where are the cysts, in which part of the kidney the cysts are going to be. In the recessive polycystic kidney disease, the cysts are going to be in the collecting ducts only. So you will only find cysts in the collecting duct. So which part is affected in embryo?
Ureteric bud.
Ureteric bud. In the autosomal recessive polycystic kidney disease, ureteric bud is malformed. It still has some kind of cysts in it. So do you think it's going to be very easy to urinate if every single collecting duct has cysts? No. So you will see that typically the kidneys are becoming super huge, they're enlarged, and you notice that the baby does not urinate much. So oligonuria, so very little production of urine in the autosomal recessive polycystic kidney disease. In the dominant polycystic kidney disease, the cyst could be in all segments of the nephron, but the collecting ducts are typically staying open. So does it mean that every single nephron will be affected? Not really, okay? In the dominant polycystic kidney disease, the production of urine is normal. It's just that there are a bit of a cyst present in the excretory tubules, like proximal convoluted, loop of Henle, distal convoluted, so there are a bit of cysts there as well. But collecting ducts are normal, so urine still passes. So if by a miracle some nephrons are free of cysts, they're still making the urine. Collecting systems are free, they do not possess any cysts, so you will urinate normal amount. So this is why dominant one, typically you realize it in the adulthood. In the adulthood, you're like, yeah, actually something is wrong. So as I'm getting more and more older, I'm making less and less urine because my kidneys are so damaged, right? So yeah. This part, I asked them, you don't need to know this. Next semester pathology, you'll talk about celiopathis. So they don't want you to talk about it. So as you can understand, right now your definitive kidney is in the pelvis. So this is your metanephric tissue, which is responsible for giving you nephron, the excretory part, right? This is the ureteric bud, which is responsible for giving you the collecting system. So now your entire definitive kidney is in the pelvis. That's not where it should be. It should ascend. There is something which is called ascent of the kidney. And this is Professor Antel's favorite thing to ask. He always says, does it really ascend? Does the kidney really ascend? Ascend means that you're moving upwards. Does the kidney move upwards? It doesn't. Kidneys stay where they are. What is moving? You add more vertebrae as you grow. That means that the pelvic region starts to be a bit lower. So kidneys themselves do not move. They stay in the normal position. But because you add more vertebrae, the pelvic part of the embryo is sort of descending, is actually going downwards. So that looks like your kidneys are ascending, while in the reality, they're staying where they are. That's always where they have been. There's some malformations that could be because of the ascent of the kidneys. Number one is the horseshoe kidney. Horseshoe kidney arises if the inferior poles of the kidneys get stuck under the inferior mesenteric artery. So sometimes because kidneys are a bit in an interesting position, they should be like that, but sometimes the two inferior poles kind of go under the inferior mesenteric artery. Because the two tissues are the same, they will fuse, right? It's like, you're my brother, let's be together. So they are going to be fusing together. So that creates a horseshoe kidney. Is it bad? No. Okay, so if your kidneys are healthy, it's okay. But as soon as you have some kind of kidney damage, as soon as something's happening to your kidneys, like maybe some drugs you took or something like this, you have renal failure. Because of this horseshoe, it will spread to the other one as well. So that's one of the disadvantages, because typically, I can just remove one kidney and I can live with one kidney. But in the horseshoe patients, the renal failure could spread everywhere. It could spread to this part as well, all the way to the other one. So then you will have to get a renal transplantation. You will have to get another kidney into your body. There's also something called pelvic kidney. It means that the kidney did not ascend whatsoever. It stayed in the pelvis. Why did it stay in the pelvis? Because it got stuck under the common iliac arteries. So the two the two kidneys, they got stuck under the common iliac artery. So the part where it is dividing into the internal, external. Okay, bladder and urethra. So as you have told me, this is the urogenital sinus. This is the bladder. So that means that if you're urinating as an embryo, you're urinating through the cloaca into the proctodeum. You do not want that to happen, so you need to separate the two areas. We talked about it last class, I think. Have we? Remember, we were trying to separate the cloaca. There was a bit of a urorectal septum here. Urorectal septum is visceral mesoderm, and it is located between urogenital sinus and hindgut, right? So here they would have been hindgut. This urorectal septum keeps on proliferating forward. It wants to go out all the way to the proctodeum until the tip of the urorectal septum is located outside. The tip of the urorectal septum is called perineal body. Do you remember what is perineal body? How do we answer this question? What is it?
Point of conversion.
Yeah, this is the point of convergence of the pelvic floor. That's the part where all the ligaments and muscles are converging. Remember, I think we talked about it. There was like a diamond-shaped perineum. Perineal body is in the center, so every single muscle and ligament could converge in that particular point. That's the strongest point in the pelvic floor. So perineal body arises from visceral mesoderm. So it's a tip of the visceral mesoderm, specifically the urorectal septum. So the name of this visceral mesoderm here is the urorectal septum. It separates your one common orifice into two. So thanks to the perineal body, now one huge proctodeum is actually two things. The urinary part, right? So somewhere here, the urinary part, and the anal part somewhere here. Okay, so lastly, this is the part which is a bit important. So this is the urogenital sinus. Could you tell me which germ layer urogenital sinus is? From where did it come from?
Hindgut.
Say what?
Hindgut.
And hindgut was which germ layer?
Intermediate mesoderm.
Hindgut,
Endoderm.
it was endoderm. Hindgut is endoderm because hindgut is the gut tube. Entire gut tube comes from the endoderm. So this entire whitish / gray area, this is the urogenital sinus, that's the bladder, and this is going to be endoderm. These blue things are mesonephric ducts. As you remember, they were conveying urine from the mesonephros. Ureteric bud is its outgrowth. So somewhere there, you used to have metanephrons, right, which are the definitive kidney. Could you tell me mesonephric duct and ureteric bud, which kind of germ layer did it come from?
Intermediate.
Intermediate mesoderm. So you can see that ureteric bud will be the future collecting system of the kidney, including ureter. You do not want ureters to open up into the bladder through the mesonephric duct. Why? So they are going to detach from the mesonephric ducts and attach to the bladder directly. They're going to find their own openings into the urinary bladder. Again, that's understandable because they are the future ureters, so they want to open into the bladder directly. Could you tell me why ureters on picture C are now superior than mesonephric duct?
Because the kidney ascends.
Very good, because the kidney ascends. On picture C, you can see that kidney was staying where it was, but the pelvis was moving downwards because you were adding more vertebrae. So as a result, it looks like the ureters are going upwards, right? The mesonephric ducts are staying downwards. This area here will be torn apart. Can you imagine? You're connected to the bladder is descending down, the kidney stays where it is. You cannot elongate the structure, you literally pull on the bladder. That's what you're doing, you're pulling the bladder. So this part, this triagonal area, will be kind of tearing apart. As it tears apart, you do not want it to tear apart. It's a bladder, you don't want to just to rip it open in the body cavity. So as it tears apart, you simultaneously repair it. This particular part, you actively proliferate here and you're actively repairing. Just a question for you, what would you use to repair? Endoderm or intermediate mesoderm? And the answer is that you will use intermediate mesoderm. The ureteric bud and mesonephric ducts are going to give you the intermediate mesoderm, which proliferates in this particular area, in this triagonal area. So the rest of the bladder is endoderm. This area is mesoderm. How do we call this area?
Trigon.
Trigon. So this is the trigon. So what is so special about trigon?
It comes from a different layer of
So clinically, functionally, what's so special about trigon?
It's smooth.
It's smooth, very good. Anything else?
It's the opening.
That's the area where the things open up, yeah? So ureters open up there and some ejaculatory ducts in men are going to be opening up. Clinically, what is important about trigon? What does it mean it's smooth? So it cannot do what?
contraction.
It cannot stretch. the rest of the bladder can stretch. So if you keep on adding urine here, it will be constantly stretching. Trigon cannot stretch. If there comes a point that even trigon starts to stretch, your bladder is so full that even trigon starts to stretch, trigon has a direct connection with your brain. There are some nerve fibers which are going directly to your brain. So your brain, if it receives impulse from the trigon area, it's going to override your voluntary control. So what are you going to do? You're going to pee yourself. Yes, you're going to pee yourself. So if trigon stretches, you will pee yourself. I think I told you the story that when I was doing my oral, I had to wait for like 6, 7, 8 hours because we used to have lecture books. So when I put mine that I was the next person to go, Jesus came and flipped the lecture book. So I was the last person to go. So again, I had to wait for an hour, 3 hours. I have a tiny bladder. So I came to, after 7 hours of sitting in that room, watching everybody's exam, I couldn't wait anymore. So I came to Clara and I was like, listen, if I'm not the next one, my trigon will do its job. And she laughed so hard. She was like, okay, just because of this, you're the next one. What is your name? You know, so like this. So it was really good. I think it kind of helped me as well that I was making scientific jokes. But yeah, okay. So if trigon actually starts to stretch, it will completely override your voluntary control. The rest of the bladder can stretch because it is endodermal origin. Trigon is actually mesodermal origin, so it cannot stretch much. These are going to be the mesonephric ducts, right? So in men, this part of the mesonephric ducts will become ejaculatory ducts, right? So this part right here, these are the ejaculatory ducts. Okay, speaking of ejaculatory ducts, let's go to the genital system. Majority of it, it's repetition from the embryo 1. So hopefully you remember embryo 1. So how do we call undifferentiated testes and ovaries?
Gonads.
Gonads. What do gonads consist of? What can you find in the gonads?
Primordial germ cells.
They will go there, yeah. But what do they consist of before that? 5th week, primordial germ cells will go to the gonads. Yes, so if this is my gonad, PGCs are going to be nearby during the 5th week. But what does the gonad itself consist of?
Epithelium.
On the surface, you will see surface epithelium. It's going to be simple cuboidal epithelium. But what's in the core?
Mesenchyme.
Amazing, mesenchyme. Okay, so that's what the gonads consist of. Mesenchyme and surface epithelial gonad. Where did this mesenchyme come from?
Also intermediate mesoderm.
Amazing. It's also going to come from the intermediate mesoderm. So it's also going to come from the intermediate mesoderm. So also because urogenital system, so urinary system comes from the intermediate mesoderm, genital will as well. So this mesenchyme, its origin is intermediate mesoderm. Here we have PGCs. What do PGCs give you?
Oocyte and spermatozoa.
Very good. If PGC is destined to become oocyte, what will it have?
XX.
Very good. So it is a diploid cell. So you will see that it will actually possess XX chromosome. If it's meant to become the spermatozoa, it will possess the XY chromosome. You remember this SRY?
Determining. I know it's the determining sex.
The sex
region.
determining region on the Y chromosome, but what does it code for?
Or
TDF.
TDF. And what is the job of TDF?
Gives us testes.
Yeah, but what does it do exactly? What happens to PGCs when they come in here?
Becoming sex cords?
Yes, they divide mitotically and they align themselves into the sex cords. In men, these sex cords stay. In female, these sex cords do not stay. They become clusters. So why do sex cords stay in a male?
Because of the
Because of the TDF. TDF has a very important job. It keeps the sex cord stable, okay? In the female, Okay, germ cells we have talked about. This is just a revision. I really love this book because literally this is like chapter number 6 or 7, I remember. Take a look. Primordial germ cells originate in the epiblast, right? Migrate through the primitive streak and by the 3rd week reside in the wall of the yolk sac. You go to the chapter 1. In the 1st chapter, it's written by the 4th week, they're in the wall of the yolk sac. So it's like this book is the worst book that they have ever chosen because it's like in the same book, every chapter says something else. Okay, so these are the gonads. These are the mesonephros. As you can see together, they are creating something which is called urogenital ridge. Remember I told you glomerulus will have a connection to the dorsal aorta, right? So that's what you can see here. This is the dorsal aorta. That's each glomerulus will have a connection to it. S-shape mesonephron is here. This is a mesonephric duct. How would you call a duct here? Paramesonephric duct. And this is the genital ridge, which will be the gonads. So as you can see, mesonephros and gonads are at the same level, together creating urogenital ridge. This picture, you remember, 4th week, that's where the PGCs are going to be at the posterior wall of the yolk sac. When do they reach the gonads?
Week 5.
Week 5. Okay, here it's just some additional things. So for example, Sertoli cells, where did they come from?
Epithelium.
Yes, surface epithelium of the gonad. You're going to see that if I go back, right? So this is my gonad. During the 5th week, some surface epithelial cells detach, go into the gonad and stay there. Wait until the puberty, right? And then become the Sertoli cells. Leydig cells, where do they come from?
The mesenchyme.
Mesenchyme, yes. So because think about it, we have used the sex cords, we have used the surface epithelium. So the only thing which is left to use is the mesenchyme. So Leydig cells, they will come from the mesenchyme. What do Leydig cells do?
Testosterone.
Testosterone production. Okay, this is a new word that you need to get. You remember sex cords? They stay in the male, right? They persist. So when the sex cords persist in the male, we call them medullary cords. So if they persist, if they stay as cords, you will call them medullary cords. So who has medullary cords, ovaries or testes? Testes, of course. Now, super weird part. So if I go back to here, super weird. In female, medullary cords do not persist, right? They dissociate to become clusters. Clusters will be called cortical cords. Cortical cords are clusters. That's the extra information that you're adding to yourself in embryo 2. In embryo 2, we just call them, in embryo 1, we just call them clusters. In embryo 2, these clusters will be called cortical cords. So remember that medullary cords are the sex cords in a male. Cortical cords are the clusters of PGCs in a female. So they have a different position, right? Okay, so there you go. That's what you can see here. These are my sex cords within the testes. So you will call them medullary cords because they're somewhere here. What was this, the S-shaped structure? Mesonephron. So this was the excretory tubule of the mesonephron. This was the mesonephric duct. This is the paramesonephric duct. We have said that mesonephros are going to be degenerating, right? Not all of them. Some of them, which are at the level of the gonads, will be reattaching to the medullary cords. some mesonephros will be reattaching to the medullary cords. So what will they give us? They'll give us the retetestis, vas efferent, right, epididymis, and then the rest of the mesonephric duct will become the vas deferens, ejaculatory ducts, and etc. So in males, you can see that mesonephros do not fully degenerate. Majority of them will be attaching to the medullary cords. Medullary cords are going to be secreting FGF9, fibroblast growth factor 9. This fibroblast growth factor 9 is attracting mesonephros. Okay, it's like, I don't know, I always give this analogy, it's like a perv in a van with a candy. Okay, so here's the candy. So your children, your mesonephros are definitely going to be going all the way here. Okay, so they're going to be attracted to the medullary cords a lot. So the candy is actually FGF9. Medullary cords will be secreting FGF9 and as a result attracting mesonephros. So quickly tell me, what will mesonephros become?
Retetestis.
Retetestis, vas efferent, what else? Epididymis, and mesonephric duct, right? The duct itself will become vas deferens and ejaculatory duct. Vas deferens and ejaculatory duct. Okay, so that's in the female, right? You can see that these are my clusters. And how do you call clusters?
Cortical cord.
Cortical cords. So they're going to be known as the cortical cord. It's very confusing in the book because they say that medullary cords degenerate. They don't degenerate, they dissociate. Okay, so they just spread and they become the clusters in the cortex, which we'll call cortical cords. This is also mesonephros, but we're in the female. Do you have medullary cords here? No. So can medullary cords make FGF9? No, they aren't there, so they cannot make FGF9. So will mesonephros be attracted to this part? No. So mesonephros start to degenerate. What finishes their degeneration? Estrogen production. You're going to see that some cells in this part will be actively making estrogen. Estrogen will finish these mesonephros from becoming anything else. They'll just simply finish their degeneration. You can see that somewhere here we have another duct, which is the paramesonephric duct. This paramesonephric duct will be actively growing, and as it is growing, it approaches more and more the ovary. So this paramesonephric duct, this area right here, that's your future fallopian tube, right? So this is the fallopian tube right here. How do you call a remnants of the mesonephric duct in the male? Oh, in the female, sorry.
The oropharynx.
The oophoron and the paraophoron, they're going to be exactly here in the mesosalpinx, right? So in the mesosalpinx, we have the oophoron and the paraophoron. Okay, so that's just the comparison between the male and the female. So the major thing, medullary cords, cortical cords, medullary cords make FGF9. FGF9 forces this mesonephros to come this way. So as a result, male structures will appear. In the female, that's not happening. So mesonephric is called Wolffian, paramesonephric is called Mullerian. We know what will mesonephric become, right? So vas deferens, epididymis, etc. Mullerian duct or paramesonephric will become fallopian tube and uterus, right? So fallopian tube and uterus. Okay, this is important. So this part right here, they can for sure ask you about it. So who has SRY?
Male.
Be a bit more specific.
Y chromosome,
Be a bit more specific.
the upper part of the Y chromosome.
The short arm of the Y chromosome. So this is the Y chromosome. The short arm of the Y chromosome will have SRY. SRY will be to will be working together with SOX9. So SOX9 is also some kind of autosomal gene, which is going to be present in the testis, in the cells of the testis, and SRY and SOX9, they work together. SOX9 is known to bind to the promoter region for anti-Müllerian hormone. So which cell makes anti-Müllerian hormone?
Sertoli cell.
Sertoli cell. So SOX9 will be binding to the promoter region in the DNA of the Sertoli cell, okay, and it will be responsible for production of the anti-Müllerian hormone. Together, SRY and SOX9, so not or, and according to our lectures, SRY and SOX9 together are forcing your testis to secrete FGF9. You remember what is FGF9 going to do?
Medullary cord.
Attract the medullary cord.
Attract the
The meta
mesonephros, okay? So it's going to be
Mesonephros.
responsible for attracting the mesonephros. So these mesonephros are forced to become the retrotestis, vas efferent, epididymis, and etc., right? So FGF9 is super important. In some males, FGF9 is not present. So the seminiferous tubules are not connected to retrotestis. So these males are born sterile, okay? So they are born like they cannot have children. So you need to remove the spermatozoas from the seminiferous tubules surgically. So you take them out. So FGF9 is super important. Steroidogenesis factor, sure, it stimulates differentiation of the Sertoli and Leydig cells. So basically, why would surface epithelial cell become Sertoli cell SF1? Why would mesenchymal cell become Leydig cell SF1? So just the differentiation is because of this factor, right? And you can see that also SRY and SOX9 are actively participating in that process. 5-alpha reductase, you remember? What does it do?
converts the dihydrotestosterone to testosterone.
The opposite.
So the opposite.
Testosterone to dihydrotestosterone will be converted by 5-alpha reductase, and dihydrotestosterone is way more active than testosterone, as you remember. Dihydrotestosterone is needed for what? Which structures will need it?
Prostate and penis.
Yes, PP, right? So prostate and penis are going to be responsible. They need dihydrotestosterone to become prostate and penis. So they fully rely on it. There is a process called viralization. Viralization means becoming a man. So for example, you know, like there are some, I don't know, Olympics in bodybuilding, right? And some females take testosterone shots to have more muscle. So we can say that these females undergo a process of viralization. So they are technically becoming a man. But what is it important for us? There is something which is called a viralization of mesonephric duct. What was the original job of mesonephric duct?
Secrete the urine.
It doesn't secrete it. The mesonephros make the urine, but mesonephric duct was just transporting that urine, as you remember, right? It was just kind of collecting it and putting it to the urogenital sinus. So at first, mesonephric duct had a urinary function. It belonged to urinary system. But then we converted that mesonephric duct in male to become retrotestis, vas efferent, epididymis, which are not conveying urine, they are conveying spermatozoas. So viralization has happened. So viralization of mesonephric duct has happened. Which hormone is responsible? Testosterone. Testosterone is responsible for converting your mesonephric duct to become the retrotestis, vas efferent, epididymis, and etc. Okay, that was for the male. In the female, the ovary determining gene is going to be the WNT4. WNT4 upregulates DUX1. DUX1 inhibits SOX9. So even if you have SOX9, it will be inhibited by DUX1. So as a result, none of these processes happen. As you see, we need SOX9 for pretty much everything. So if I simply inhibit SOX9, these processes will not happen. So that's the overview for you. Okay, so now we talked about this part. So this is just basically what becomes what. You remember we said that Mullerian duct is not formed in a male, right? So it leaves some kind of remnants. You remember the remnants?
Appendix of testis.
There's also prostatic utricle. I always forget this one, always. Okay, so also prostatic utricle. 5 years of my tutoring, I always forget it. Appendix testis, it's known, but also the prostatic utricle is also a remnant of Mullerian duct in a male. Okay, so now genital ducts in the female, what is happening to them? So this is the urogenital ridge, right? So this is the posterior body wall. This is the anterior body wall. How do you call this?
Neural tube.
Neural tube.
Notochord.
Notochord. This
Dorsal
one.
aorta.
Yes, dorsal aorta, very good. This one.
Got you?
Gut tube. This is probably like hind gut because it's a bit more downwards, right? So this is like mid gut becoming hind gut, yeah. This is the urogenital ridge. Which germ layer gives you urogenital ridge? Intermediate mesoderm. What can you find in the urogenital ridge? You can find mesonephros and gonads. Because we're in the female, inside of these gonads, you can find
Cortical cord.
cortical cords. You'll find cortical cords. So these are just clusters which consist of the PGCs, right? But we call them cortical cords. 2 dots are here. Blue one is mesonephric. The pink one is the paramesonephric duct. What is happening in a female? 2 paramesonephric ducts are approaching one another because they want to fuse. And that's exactly what is happening. The 2 paramesonephric ducts are fusing together. When they fuse together, a structure arises, which is called uterus. So when the 2 paramesonephric ducts approached each other and fused together, uterus is being formed. So this is uterus. But because of repositioning of the paramesonephric ducts, you can see that some things have actually changed. Like what? Position of the ovaries. At first, ovaries were facing anteriorly. But because paramesonephric ducts were moving, urogenital ridge also moved. It kind of pushed it with it, right? So you can see that the position of ovaries have changed. Now they're facing posteriorly. And urogenital ridge has become something. What has it become?
Broad ligament.
Broad ligament, yes. It's going to become the broad ligament of the uterus. So this kind of urogenital ridge, it's just mesoderm, intermediate mesoderm. It will become connective tissue. Which kind of connective tissue? The broad ligament of the uterus. So now it kind of attaches your uterus to the lateral walls. Thanks to the urogenital ridge, thanks to the fusion of the 2 paramesonephric ducts, the cavity is now divided into 2, right? So there's one cavity here and there's one cavity here. So uterovesicular pouch and uterorectal pouch. Uterorectal pouch is also known as
Douglas pouch.
Douglas pouch, yes. Okay, so it will also be the Douglas pouch. So everything is because of the paramesonephric ducts. So you can see that here are paramesonephric ducts and they are fusing together, right? And they're creating one uterus. In some females, they don't fuse. So there is a septum here. So technically that female has 2 uteruses, one here and one here. It actually happened in the UK a couple of years ago. There was a girl giving birth from 2 uteruses.
So you get like 2 times pregnant?
Yes, that's exactly what happened. She had sex like, I don't know, for example, I remember in September, and then she had sex in, I don't know, December. So one child was born like, how do you call it, my God? Недоношенный. How do you say it in English when you're not...
It was premature.
Yeah, premature. Okay, so the one child was born premature, because can you imagine if one uterus is contracting, the other will also be contracting. So one child was born premature.
But they're not twins.
No, they're not twins. They don't even have the same father. It's just 2 siblings that are like, you know, sharing a womb. And I will never forget, it was the highlight on the news. Miracle birth. Like, bitch. Oh, miracle birth. Okay, sure. But yeah, that actually is happening. But I also want to get girls' attention. Can you imagine having 2 uteruses? Can you imagine the...
I cannot handle with one, so with
Exactly.
2.
I cannot handle one. Like, can you imagine the menstruation? Can you imagine?
2 periods.
Yeah, one doctor asked her, "You must have had heavy flow, you know?" And she was like, "Yeah, but my mom told me that runs in our family. We're like the heavy flowers, you know." That interview was insane. Like, it was insane. But yeah, okay, so that happened. That does happen. Anyway, so this is your 2 parmesonephric ducts fusing together, and they should not have a septum here. It should be 1 uterus, right? So like here. But now we need to talk about how do we make vagina. If I go back, let me go back all the way back. No, not here. Okay, let's do it with this. How did we call this?
Urogenital sinus.
Yes. And who was attaching here?
The
Mesonephric duct, right? It was opening up here. You're going to see that paramesonephric duct will also open up here, but a bit lower. Technically, it will open up to the urethra. So you remember urorectal septum separated this area completely. So we actually had urethra. So paramesonephric duct will be opening up to the posterior surface of urethra. So if I must have put the picture. Yeah, there you go. I didn't even need to. Anyway, so this is the primitive urogenital sinus. Here, the mesonephric duct would have been opening up, right? You can see that here we already have urethra. This is the anal region. This is the perineal body right here. So that's the tip of the urorectal septum right here. So posterior urethra has some kind of swelling. The swelling is called sinovaginal bulb. So your paramesonephric ducts are attaching to the sinovaginal bulb. I repeat, it is a posterior surface of newly formed urethra. Sinovaginal bulb, which kind of germ layer is it?
Ectoderm.
It is part of the urogenital sinus. So,
Intermediate.
and endoderm. Don't forget, hindgut was going backward, cloaca, then urogenital sinus. So all of this was actually endoderm. So this sinovaginal bulb is endoderm, and you can see that 2 paramesonephric ducts, when they're fusing together, they are attaching to this sinovaginal bulbs right here, right? So fusing together. So what's going to be happening next? You're going to see that your sinovaginal bulb starts to proliferate forward, keeps on proliferating until vagina is formed, until most of the vagina is formed. But do you see that initially vagina was opening up into the urethra? So if the embryo was peeing, we needed to protect the vagina from whatever fluid was present there. So there is a bit of the mucosa present here, which is covering the sinovaginal bulb. How do we call that mucosa? We call it hymen. Hymen is the same as oropharyngeal membrane or cloacal membrane. It has just protective purposes. So it should have ruptured by the time you're born. And in majority of the times it does. There are lots of girls who are born without hymen. So when they have first sexual intercourse, do they bleed? No, they don't bleed. Okay, and it's a major problem in where I come from, because I come from a horrible, horrible place, Middle Russia, Stone Ages, basically. So if you don't have a hymen, that's it. Basically, you're screwed. So in Russia, and surprisingly in Iran, there's a surgery. It's called hymenoplasty, where you take a little bit of the vagina, okay, and you sew it just a bit. Like you sew it just a bit, creating a little tiny membrane-like structure. So when the penetration happens, you will penetrate that sewing, it will create blood. So the man will think that you're a virgin. It's just really funny because personally, a couple of my friends who I love adorably, are biggest sluts in the world, they recently got married through that. They basically had hymenoplasty. Okay, so they came back and they're like, listen, I'm as pure as, I don't know, as the little tiny spring flower. Okay, so it was super funny and everybody knows, and even probably man himself knows, but just it was very important for culture wise to have the intact hymen. So that's why I always laugh at it, because it literally is a little tiny membrane which was supposed to simply protect the developing vagina from the urine that was created by embryo, but then it was actually kind of persisting there. Okay, so very important is this. You can see that only the distal part of the vagina is endoderm. The top part of the vagina is actually also paramesonephric ducts. So Mullerian ducts will also proliferate forward and will create the top part of the vagina, specifically the two fornices, right? You know, the anterior posterior fornices of the vagina, they will come from the paramesonephric duct. Because this is paramesonephric ducts, sometimes the septa goes down. So you remember we said there's some girls with two uteruses? There's some girls with two
Vaginas.
Vaginas.
Yes, you can Google that. It's a thing. Okay, so where you see that this paramesonephric duct, this septum goes down. It goes down like that. So there are two vaginas. Fun things. Okay. Okay, so I'm gonna quickly tell you this and I'm gonna let you go. So next class we'll continue with this part. It's quite easy. There is something called indifferent stage of the genitalia. Basically, it means that doesn't matter if you're a boy or a girl, you must have it. It's indifferent stage. So it's the stage which is present in both genders. This area is present in the cloacal region, just a bit outside. So these are swellings on the ectodermal outer side of the cloaca. So, you know, cloaca is down in the pelvis, but its outer layer, of course, will be ectoderm. So there, specifically during the 3rd week of development, you can see that there's going to be a bit of the mesenchyme present, which is covered by the ectoderm, and this mesenchyme creates some kind of swellings. Okay, so it creates some kind of swellings. Which kind of swellings? For example, genital swellings, for example, cloacal folds. You can see that between the cloacal folds, there's actually cloacal membrane. And most superiorly, there is another swelling, which is called genital tubercle. A question for you guys. Will neural crest cells participate in making it? Because remember, we always say mesenchyme, neural crest cells, mesenchyme, neural crest cells. So here we do have mesenchyme. In the core of the structure, we do have mesenchyme. So will neural crest cells participate in forming genitals?
No.
Yes or no?
No.
No. It's a correct answer, 50-50, but it is a correct answer. Okay, so it's a no. Why no? Why not? It's a bit too far away. So majority of your neural crest cells will be here. That's your heart and your face. So cephalic cranial region, that's where neural crest cells love to accumulate because it's closer to your neural tube here. right? Your neural tube will finish in the lumbar region. This is coccygeal, I don't know, outside, so that's why it's too far away. Neural acquired cells will not be interested in this mesenchyme here. They are not even aware that there is mesenchyme there. Okay, so that's why neural acquired cells will not be here. Now, here you can see that something has happened. Perineal body is here. Perineal body is here. So what have happened?
Invagination of the membrane.
Not invagination, but if I tell you that this is perineal body, so what have happened?
Splitting.
Splitting. You remember one cloaca was split into two parts, into the urinary part and into the anal part. So you're gonna see that a bit later, so this is already like 4th, 5th week, you start to see that the perineal body is formed. So one cloaca is divided into two. Perineal body is going to be here, into the anal region and into the urinary region. So these become urethral folds, and this one becomes anal fold, right? So these cloacal folds will kind of become two things. This will be the urethral, and this will be the anal. So in female, nothing changes. That's what we will learn next class, that there is absolutely no changes whatsoever. So it stays as it is. So what do I mean? The genital swellings in the female will become labia majora. The urethral folds will become the labia minora, and genital tubercle will be the clitoris. The urethral opening will be just below it, right? So as you know, clitoris is a bit up, urethral opening is a bit downward. So that's where the urethral opening will be. In men, there will be lots of changes. We'll talk about it next class. You're gonna see that we have genital tubercle here, which will be elongating and creating phallus. That's the major part of the penis. If phallus is elongating, you see that the two urethral folds come close together, right? So they're approaching one another. If they approach one another, which surface of the penis will that be? That will be the ventral surface of the penis, right? So the underside of the penis. So these two urethral folds in a man will fuse together and they will create the ventral surface of the penis because genital tubercle is elongating along. Could you tell me what is the reason for elongation of genital tubercle? Like what causes it to elongate? Yes. Dihydrotestosterone. Yes. Dihydrotestosterone is going to be actively responsible for this elongation of genital tubercle. What will the genital swellings become in a man? They will become the scrotum. So they will come forward. We'll talk about it next class. They will come forward, protrude downwards, and create the scrotum itself. Okay. Okay, so see you tomorrow.
When?